I am Matthew Arthur, CEO for Longwood Publishing. To help welcome us this morning and our speaker, I would like to introduce from IHPME, the Dalai Lama School of Public Health, and the director of the North American Observatory on Health System Policies, Sarah Allen. Sarah.
Great to see you all here in the room and welcome everyone online. I'm Sarah Allen, an associate professor of health policy here in the School of Public Health. And I'm also co-editor-in-chief of Healthcare Papers, Longwood's journal. So I'm really delighted to be here to support Longwood's and to welcome our esteemed speaker today to this session, Dr. Jennifer Zellmer. She did her PhD in economics and then traversed the health system in many leadership roles with a persistent sort of focus on patient safety, improving quality, and identifying and scaling innovation and improvements throughout the country's health system. So in many of her roles, she was leading some of the critical agencies that are kind of like the glue that sticks Canada's health systems together, those intergovernmental agencies that are really critical in a decentralized federation like Canada. So in Canadian Institute for Health Information, Canada Health Infoway, and most recently as the inaugural CEO of Healthcare Excellence Canada. This is the new organization that was an amalgamation of two of those, critical pan-Canadian health organizations that came together to be even stronger and even more sort of fundamental to improving healthcare in Canada. Those were the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. So in her work, she's been leading the sort of health system changes that we desperately need, and we're really grateful to have a few minutes to hear from her thoughts and leadership in rethinking and improving patient safety in Canada. So without further ado, I'll turn it over to Dr. Zellmer, and we really look forward to having some time to hear from you and to have some engagement in Q&A. So welcome and thank you for being here.
Thanks so much, Sarah and Matt, and thanks everyone. And as Matt said, it's a good idea to take some time to learn about the place where you're. There we go. Nothing like having that in your ears, so hopefully that's better for folks along the way. And one of the things that I've learned about this place where we are here today, for those of us in person, is that the word Toronto comes from the word Takaranto, which means place in the water where the trees are standing. And so if we think about, as you came in today, you may or may not have seen the trees and the water, but this is a place that for a very long time has been a gathering place, a place of learning and exchange, a place connected by the water to many other communities, and a place where people have come together to learn and to share. So hopefully today, in this way, us together in this room and with everyone online, we have an opportunity of continuing that cycle of learning and exchange and of being together. And I invite those of you who are online, hello online, I invite you to pop into the chat who you are, where you're joining from, so that we can, those of us in the room have the buzz over breakfast of being able to introduce each other and say hello, so that you can join in that as well. And for those of you who've just joined, as Matt has said, for those online, feel free to pop questions in the chat at any time. And for those of you here in the room, we'll be able to have questions and conversation as the conversation goes along. So with that, Matt, I'm wondering if you can bring up the slides for me.
That's audio problem.
We're working on some audio problems. Excellent. Well, dancing is not my thing. So I am not going to be doing that, although I will tell you a story about that while Matt is dealing with the technology. So when I lived in Toronto, the health sector is all about relationships, right? Everybody's been there. It's all about relationships. And so a group of us got together and all of us worked in different organizations in the health sector. Maria's laughing because I think she's heard this story before, so she knows where I'm going with this. And we decided that we were going to learn as adults to tap dance.
Oh, no.
Now, the rules for coming into this process were that you could not be coordinated, you could not have danced as a child, and that you accepted that the most important part of this process was the dinner before the class. So as long as we were all on that same page, we were there. And to this day, many of the relationships that I forged through that process are an important part of how I see things going forward. And I'll just move over because I think I may be slightly out of the camera angle for this slide. But let me get started with our conversation today. And it actually relates to what I just said, because I remember that experience tap dancing. I couldn't have told you exactly when our classes were, or exactly what I was doing in a particular year. And if you think back to this time in previous years, you could probably, if you're like me, I know where I was this time last year. And I'm willing to bet that all of us could tell you where we were in May 2020 because of world events. But 15 years ago, 12 years ago, you might have to think back. You might have to work out where were you based on what was going on in your life, what was going on in the world around you. But 20 years ago, I can tell you exactly where I was and what I was doing. Because 20 years ago in May, we just provided under embargo a study by Ross Baker, Peter Norton, and colleagues, the Canadian Adverse Events Study. And so that study was in the hands of folks across the country ready for release. And so I was answering a whole lot of phone calls at that time and a whole lot of emails because we co-funded the study. I was at CIHI at the time with CIHR. And so we're part of that process preparing. And it was in May 2004 that study came out. And in May 2004, the study had looked at hospitals across the country, medical surgical admissions for adults. And they found that in 7.5% of the cases, people had experienced an adverse event during their hospital stay. And slightly more than a third of those were deemed highly preventable. And when you looked at the outcomes of those individuals who experienced events, they estimated between about 9,000 and slightly over 20,000 people had died following an adverse event in hospital. And so that really focused attention across the country on patient safety, on the significant and important gains we needed to make in patient safety as we move forward. And there's been a ton of work between then and now. Work at local levels, work at provincial territorial levels, work at national levels. We're not by any stretch of the imagination out of the woods. So the latest CIHI data on hospital harm, and so it's a slightly different measure than what was looked at in the study. The hospital harm data looks at events that are experienced where likely with evidence-informed interventions that we know about, they were prevented. And there continue to be a significant proportion of people who experience those events. In fact, pre-pandemic, it had been stable at about 5.3%, 5.4% of hospitalizations. And then when the pandemic hit, that went up to 6% and has stayed at 6%, has not come back down. And the difference of that increase can be explained in large part not by obstetrics, not by peds, not by procedure-related events, but by medical complications. So fluid imbalances, delirium, other types of issues like that. And I'd be willing to bet, we can do a quick straw poll now. It's not just about hospitals, right? So for how many people, I'm included in this, would you or a family member have experienced an issue in your care in the last 2 years? Family member or yourself? Yeah. So it's a significant challenge. And in this room, more hands went up than the stats would suggest across the country. Now that can be due to a whole bunch of factors, including the fact that we're aware of these things. So we're on that track of looking. But it remains an important set of considerations for all of us in all aspects of healthcare. And when we look at what people say are some of the most common types of events that they experience, issues like misdiagnosis, which is the focus for this year's World Patient Safety Day in the fall, so heads up that that's coming, are right at the top of this, alongside more traditional events that we. And so it's not just in hospitals, it's across the board that this is something we need. And as we do that focusing, this is not something that has just been, that I'm just sharing with you now, right? This is something you're probably living here every day. I know many of you are focused on patient safety and quality issues because we had a chance to talk over breakfast in terms of what you care about and where that brings you. And it's also something that all federal, provincial, territorial governments recognize. They've recognized that the health system is under strain right now, that there are significant challenges that existed pre-pandemic, but the pandemic has exacerbated those challenges. And that includes not just the events themselves, but also the culture of safety. So there was some global work that was done comparing what proportion of people working in the health system feel that they can speak up about issues that they see, that they can challenge folks who are more senior to them. And so I'm not sure that the folks online will be able to play quite the same way as the folks in the room, but all of you can play. So think about that. What proportion of people working in the health sector do you think would feel safe to speak up about issues that they see or to challenge folks who are more senior to them? We'll do it out of 5. So how many people think 5 out of 5 people would be speak up? Yeah, no hands in the room for those of you online. 4 out of 5. 3 out of 5. No hands up yet. 2 out of 5. And start going up, probably half of the room. 1 out of 5. Okay, the rest of the room, anybody at 0? Didn't see. Everybody's hands gone up. So everybody was either at 1 or 2 out of 5. The answer is 1 out of 5 again. Which puts us at close to the bottom of that global comparison. So we have work to do on a number of fronts. We have work to do not just on the mechanics of specific types of safety events, also on the culture of safety within our health, and work to do on that front as well. So those are the challenges that I want to talk about this morning, because I want to talk about them in the sense that every system is perfectly designed to get the results it gets. And so that's true of our system too. Systems are based on mental models. And so the mental models of that system, which can be really helpful. We all need mental models, right? Think about it way back when. If we had to do a full risk analysis with a saber-toothed tiger coming towards us, about whether we would try and catch the saber-toothed tiger or run into the cave behind the fire, we needed a mental model to make those decisions quickly. So there are good reasons for mental models. There are ways of abstracting from a very complex set of processes and making decisions more quickly in ways that are typically helpful. But sometimes they become unhelpful and not. So they can send us into a state of rigidity, a state where we cycle. Because every time we try and come up with the same mental model brings us back. And so if you think about the number of times that various reports have been written about the ways that we might make changes, and sometimes we circle back and say, hey, that report that was written 5 years ago, it looks a lot like the report that was written now. Is that an example of our consistent models and circling back? So how do we break those mental models? How do you think differently? Because what got us here won't get us there. So we need to think about a different approach to care and a different approach towards safer care. And that's really our opportunity. So how do we think differently about mental models? And how do we think differently about the ways that we might approach care? I think I'm toast on my slides. So I have a great fun example that will not be circulated as part of the slides afterwards, because if you've seen it once, it's totally destroyed for the rest of your life. So we'll just have to, if you want a private example of that, I'm happy to share that with you offline, but I'm not going to have it out on the web circulating. But what we know, back up, I'm being told. Thank you. So I think that's making the audio worse. Okay. Is that better? Better. Yeah. At least better than my ears. Less of a ringing. Okay. So I'm standing here. I'm midway to the doors. I'm right at the edge of the podium. I'm going to ask for help for those of you in the room. If I stand a stray too far, because I do tend to walk and move, if you can just give me a high sign of like, punch it over, that would be great. And that would be collaborative and cooperative with all of your friends who are online today and supporting our collective effort in this. So you'll have to miss my example, but what we know about mental models is that ways of breaking mental models typically involve having different people at the table, people who come from questions from a different perspective. That it can mean thinking differently about the ways that you approach problems, so using different approaches, forcing functions to think differently, to require you to go down a different path, to not just default. So really good example for me, I lived in Denmark for a few years for an international organization, and I learned a ton just by being a patient in the Danish health system, including the fact that my Danish teacher moonlighted as a Danish teacher, but in her day job, she was a receptionist in a physician's office in primary care. Okay, so because of that, she had all sorts of insights to share about the world in which she lived. And of course, that did not happen straight away when I was doing the hello, my name is stage in Danish. But once I got to the stage that we could actually have conversations, I learned a ton from her. And I learned she'd recently become a receptionist in that primary care office. Her background was as a flight attendant. She did all the vaccinations in that office, which blew my mind because it was so outside the scope of the ways that we would do things around here, right? So that was a mental model change for me. It required me to think differently. And as we think about patient safety, some mental models can continue to be super helpful. So one of the ones I like, you may have seen it, James Rees's Swiss cheese model. So think about slices of Swiss cheese, where different types of risks are coming to hit the cheese. And sometimes the cheese is solid, right? So there's a protection in place. Maybe there's a system, a structure, a process, a set of education that stops that before it hits a patient. But sometimes the holes will line up and the error will come through and it will affect the patient at the end of the day. And so our challenge is to think about how do we shrink the size of those holes? How do we thicken the cheese? And how do we add more slices with more barriers so that things don't come in? And how can we change our mental models to be able to? And so that's one of the things that we've been thinking about in terms of patient safety. So if we continue to think about patient safety in the way that we always have, are we going to get to a different place? Or do we need to start thinking differently? And so we did a whole series of consultations, and Carol's here, she's very involved in the work, others have been as well along the way. That's bad. Yes, I definitely don't want to hear that sound. Thanks, Matt. Just do a quick check and see, yes, you guys can still hear. Excellent, good, good. So rethinking patient safety is about how might we change our mental models around safety in ways that get us towards safer care, in ways that allow us to move to a different place. And the first part of rethinking patient safety is that patient safety is everyone's responsibility and opportunity. So no matter your role, patient, family member, formal person with a business card in the health system, and that could be in any role, you have an opportunity to work towards safer care and to contribute to safer care. But it is something that needs to be done together. It's not something that one person on their own can typically do. It is about how do we bring together that culture of safety that has open communication, that has mutual respect and support, that has an opportunity to, if I go back to that 1 in 5 stat that I talked about earlier, that knocks that on its head. That means that we can have different kinds of conversations. And it is about both learning and acting. So absolutely, we need to learn from past harm, super important. And we also need to be able to understand how safe is care today, right in front of you, right in that circumstance. And how safe will care be tomorrow based on changes that are happening, based on the environment that's altering, and so on. So all of those different dimensions are important and allow us to think differently, because the absence of harm does not mean safety. The absence of harm might just mean you were lucky today. So how do we try and build in safer care by design, not just by luck? And then as we think also about all types of harm. So traditionally, we've often thought about physical harm. So we've thought about, for instance, falls. We've thought about wrong site surgery. We've thought about those kinds of physical events. But we know that harm can also be psychological. Harm can occur for both patients and providers. Harm can occur in many different dimensions. So there's cultural safety to consider. There's questions that cross a whole range of different types of harm. And harm can also be exacerbated depending on how we respond to a given event as well. So it's taking that full lens and full perspective to patient safety that will help us to move forward towards safer care. And if that's something that resonates for you and you want to bring that back into your own environment to both think about it more yourself, but bring others into that conversation, I invite you to look at the Rethinking Patient Safety discussion guide and start those conversations about how do we nudge towards that culture of safety? How do we nudge towards safer care today and tomorrow? And use, yes, our understanding of past harm events, but as a springboard towards that opportunity. And if we think about that sort of change in mental model around patient safety, I think sometimes it can also be hard, particularly when we see, you didn't see the graphs because you didn't see my slide, but imagine, that's my virtual impression of slide. Hope you like the sound effects that went with that. If you think about that kind of change in patient safety with the pandemic, it can feel depressing, honestly. So I think it's also important to think about the fact that we know we can change because we have. We have seen fundamental changes, step changes in the safety of care in so many areas. And I want to start by sharing a story with you. It's a personal story for me. You'll have to imagine, no slides, a picture of a woman smiling. The point at which the picture is taken, she's in her 80s. But she's got a grin side to side, ear to ear. And she's my grandmother. So she has shorter hair than I do at the moment, very curly. And she was super active in her community. So my grandmother was the one who was a member of like everything in the community. Every mayor knew her because she was responsible for like some of the organizing of the Calgary Stampede pancake breakfast. And everyone in the Rose Society knew her because she was the one you went to if you wanted to order a plate. And all of those kind of things. And she had a freezer full of baking that she brought to all of the bake sales around the place as well. And to every single healthcare provider's office too. That was part of the process. And she had a lot of different health problems. And so over the course of her life, she had several hip replacements and more than one knee replacement. And during one of those surgeries, she received tainted blood. And so Hep C came with that surgery. And that had significant effects on her life, as you can imagine it would have. But if I was getting those same surgeries today, I'm about the age when she got her first joint replacement, I would not have that same risk. I would not face that same risk because systematically we have addressed that risk. Similarly, I'll stay with the long-time time horizon because I started there, right, with my 20 years back. So if you go even further back and you look at maternal mortality, you see that maternal mortality had a deep dive over several decades. So that the risk that my grandmother would have faced when she had her 4 kids, or even the risk that my mother faced when she had me, not the same as the risk that folks who are having kids today face. And so many things went into affecting both of those changes, right? It wasn't one thing. It wasn't one person. It was policies, it was practices, it was ways of thinking differently, of organizing services differently, of systematically year over years with thousands of people across the country building in towards safer. And now to bring it, like, fast forward a little bit more towards the current, those changes continue. So we have the very great pleasure of working with teams across the country, including in areas like supporting person-centered care and long-term care that allows decrease in the use of antipsychotics for people who don't have psychosis. And we know that when we do that, you decrease the risk of falls, you improve quality of life, and you make a variety of other changes that have knock-on beneficial effects that aren't just about the particular prescribed. And we know that working systematically, so for instance, we're just wrapping up in Quebec, a series of work around working with every single long-term care across the province to implement person-centered care practices in ways that we've shown improve care. And in one of the first waves of that, there were formal studies. And in that formal study, 77% of people who had been prescribed an antipsychotic either had it stopped completely or the dose reduced. And that's not because they were just writing scripts differently, right? It's because they put in place different person-centered care practices. So one of my favorite examples, possibly because I can see this being me, was someone who in their working life had been in a lot of meetings. And we're now, yes, so all of my colleagues right here are laughing furiously at the number of meetings I've been. And so when they were in long-term care and there were meetings around shift change, those were happening in the nursing station in that long-term care. And the resident could see those meetings happening, but felt excluded in those because they had always been the person in the meeting. And so they got agitated when those meetings happened. And by identifying that as a risk factor, then they were able to adjust, right? So he was invited into the meetings when it was appropriate. He was given a folder and he was invited to be part of that process. And when it wasn't appropriate, there was an opportunity to engage in a different activity. And so where are the ways that we can think differently that get us towards safer care at a macro level and at a very micro level, patient by patient, person by person? So we have the opportunity to rethink patient safety and our mental models around patient safety. And then we have the opportunity to implement safer care by design, not by luck. Because we know we can change because we have, but it takes work. All of those examples I gave you, they weren't a click of the finger. They weren't somebody deciding one day, oh, we're going to change this now. They were systematic efforts by thousands of people. So how do we actually do that? Well, the good news is we actually know quite a lot about what we need to do. So, there's been the opportunity to study high-performing health systems around the world in terms of what are the key characteristics that enable us to move forward towards better, safer care, and to look at opportunities for measurement and monitoring of safety that allow for action as well. So we need, for instance, leadership for safety. So 4 sort of core cross-cutting things, right? We need leadership for safety. And that leadership has to happen across the health system. And when I say leadership for safety, I, yes, do mean formal leaders in the health system. I also mean folks like governors. So is your board on board? Do they understand their fiduciary responsibilities related to safety? Many board members come from other sectors. This is not their world, but they have fiduciary responsibilities. If you're not sure, that's an opportunity to think about getting started. And small plug, we do have a brand new release. It's free, it's online, set of tools to support governors in their roles. We also need to enable frontline actions related to safety. And that means supporting folks to be more comfortable in terms of speaking up and being engaged, but also to support them with the resources and tools and the needs to be able to move forward. So we were talking just a little bit before the breakfast got started this morning about the fact that there's a lot on healthcare providers' plates right now. It's super busy time, and it's been a super busy time. So there's, people are tired. So how do we create space to be able to do this kind of? And one of the opportunities is to ask a pretty simple, seemingly simple, right? It's always the deceptively simple that gets you to different places, set of questions around how do you do things this way? And nobody would let me call it this when we had this as a theme for Canadian Patient Safety Week, kind of stopping the stupid stuff. So how do we streamline, reduce the administrative burden? How do we streamline processes that allow us the space, first of all, to be able to breathe, and second, to be able to think about how do we move forward towards safer care? How do we engage patients, families, and others in community as part of this process as well? This has to be about everybody. It can't just be about some of us. It has to be about everybody. But that engagement needs to be done well, because it's not fair to ask somebody to speak up if they then feel that they've been threatened or at risk because they have. So how do we create the opportunities, the cultures, the environments for being able to do that? And last but not least, how do we support people with the tools and the structures that enable safety as well? There are all sorts of things that we now know. We don't have to reinvent them. You and I were talking about this earlier, right? We don't have to reinvent them. We can reuse and recycle and spread and scale safety knowledge and interventions, just as we want to spread and scale particular changes in care. And so we want to go from innovations where it's happening somewhere to spread, it's happening elsewhere. Other people are now starting to adopt that particular approach. And when we think about that at that spread stage, we really need to learn what are the core elements of that innovation that you absolutely need to double down on, you need fidelity to get to results. And where do you need to actually adapt to a different context, to a different set of circumstances in order to be successful? And so figuring that out is key at the spread stage, which takes it to scale, which is now it's happening everywhere. So that everyone, regardless of where they live, what they look like, who they love, what kind of condition they have, has the benefit of those safety as well. So it's those cross-cutting foundations that enable us to act. And then there's the individual things, whether it's falls, whether it's pediatric dental emergencies, whatever the circumstance is, it's applying those core foundations to the individual opportunity to improve. And the opportunities to do that each and every day. And coming back to my theme of we know that we can do this because we have the really good fortune of working with more than 4,500 teams across the country, teams and communities who are engaged currently in this journey. And the places that they're working on are so different, fundamentally different from each other, but what they share is that commitment to excellence in care and the commitment to moving forward. So in that context, I'm just checking my time, excellent, I'm right on time. I also invite you to think about what's the possibility in your context. So none of us can do everything, but all of us, each and every one of us can do something. And if we add up that relentless incrementalism, each and every one of us sort of pushing that ocean out just a little bit further, those small changes can add up to big impact, as we have seen in the changes that have already been made. And so that means identifying people who are working on wicked problems, connecting with each other, spreading and scaling the rapid adoption of proven innovations, but recognizing we can't just work innovation by innovation. We also have to work on building capacity, those fundamental core cross-cutting pieces of work. And It can't just be about individual teams and frontline folks either. It has to be about how do we actually catalyze the policy and structural change that will make the right thing to do easier to do. We need all of those. And so I'll end here on one example of that and then invite you to think about what's your contribution to this process. So we had the opportunity of working with a whole series of paramedics across the country. And there they were focused on, it started with, individual innovators who in a couple of different provinces had come up with related but different solutions, right? There were adaptations to local circumstances, but a common core, which was to say, how can paramedics support palliative care in the home? So that you didn't have to always, because like any other emergency, emergencies do not always happen Monday to Friday, 9 to 5. So if you were out of hours and a palliative care team wasn't available, you did not always have to transport to hospital, which is not where most people wanted. And making that change for paramedics to be able to support folks in the home required action on so many different fronts. It required training paramedics. It required connecting paramedics and palliative care teams. It required changes in policies locally, for instance, around like, were you allowed not to transport? Or did you have to transport? Was that part of your protocol? It required changes in scopes of practice. So it required provincial regulatory changes. And it required federal changes because it required the feds to say who can actually administer different types of medication. All of those changes were required. And that set of changes then scaled across 7 provinces. And what they were able to show at the end of the day is that in over 80% of the cases, the paramedics were able to address the presenting complaint. The majority of the time, they did not have to transport to hospital. And it actually saved the paramedics an average of 30 minutes. Because there's a reasonable amount of time when you transport that you're sitting outside or you're waiting with the patient, right? So there was a time savings. So it was better for the individuals, it was better for their families, it was better for the paramedics, and it was better for the health system. And most importantly, it was better for those experiencing care. And if you ever need a dose of optimism about the difference that a commitment to change can make, all you need to do is talk to some of the folks who experienced this different model of care when they had experienced something else. And it will fill your cup and fill your heart and motivate you for the rest of your life to keep going. So with that, I invite you to think about what is the piece that you will keep going on? What is the step within your context? Maybe it's pulling up rethinking patient safety and having a conversation with those you're involved with. Maybe it's thinking about how do I get my board on board and engage folks that way? Maybe it's thinking about supporting different types of team-based care in your environment, or bringing somebody who's already done something that you're working on and learning from them about how to do that. There's so many different things it could be. And if we each do that and keep doing that, then many others will have the experience that I have had, that my risk as a person now, I hope I don't need a hip and knee replacement. I hope that risk is also changed. But if I did, my risk of having what happened to my friend is fundamentally different than when she had. And it's that promise of safer care that we want for ourselves, that we want for those we're caring for, and that we want for everyone. So thank you so much. I'm looking forward to our discussion today, and apologies for the slides. I will, probably not immediately, post them on LinkedIn so that if you want to see what slides you missed, minus the fun exercise that you have to contact me for separately, those will be available too. So Matt, I'll turn it back to you.
So again, apologize. They will be made available immediately.
So we'll do a few Q&A here, and We'll start with the audience. If anybody has any questions, don't be afraid. Now's your opportunity. I will also, hang on one second. I don't mind putting people on the spot, so I will be, so if you're unsure, then okay, here we go.
Motivator, excellent.
Thank you for the presentation, it's great. We're thinking about rethinking patient safety. And unfortunately, no. We measure safety by the lack of safety. We measure safety by the number of incidents that we have. And that's not safety, that's the opposite of safety. What about if we change that mindset? I mean, instead of measuring what's going wrong, which is not quite often all the time, we try to think about safety in measuring the things that go well. I mean, when we do things well, instead of measuring and talking about faults, say, well, you know, we saw 1,000 patients today in the visit, in the consultation, and everything went fine. What we did to make that happen. And I believe, this is not me speaking, this is the safety perspective, basically. How do we change that mental model that we have in people right now? They only look at faults. You try to start this conversation, and I have to say that people don't get it. I don't know why, but they don't get it. So I think the big help would be, how can we start that conversation and really start thinking about safety as a safety and not as the lack of safety?
So such an important question, and you're right, you know, this is absolutely the safety 2 mindset. I think there's a couple of things. First of all, the change in mental model starts with the absence of harm does not equal safety, right? So that's a place to start that conversation. And then I think there's a series of tools that we can start to use, and more are being developed in this front as well, that can be entry points for folks into this conversation. So, you know, for instance, there's pre-briefs, right? We're used to doing debriefs after an incident. So flip it. Okay, we're going to do a pre-brief. We're going to be doing the next 100 hip replacements, to keep with my grandmother's example. How do we ensure that everyone is safe through that process? By learning from the last 100, where maybe everyone was. So how do we build on what we know works and ensure that that's going forward? Because if we think back to the Swiss cheese model, right? Sometimes, most of the time, any potential errors do get caught. And so where do they get caught? And can we reinforce those places where they get caught so they don't reach a patient? I think we can also learn from some things, and you know, we've been doing this recently, and many organizations are already doing this in the cybersecurity space. So in cybersecurity, they often do tabletop simulations. Full disclosure, I'm on the board of Simulation Canada, so I would say this. But there's opportunities through simulation, I think, to have people look around that corner at how do we build from the things that reinforce, that support, that engage with safety in ways that are more tangible and visceral than just an open conversation around saying, you know, it's important to think about the positives too. So I think there's some tools and techniques that we can use that will help on that path. Does that make sense? I think there was another.
There is, but I'll go online first.
Sorry.
So the question is, are you seeing a shift in the curriculum for students, specifically undergrad, as hospitals are not making it top of mind for the residents?
It's a good question. There are, in all of the professions that I'm aware of, I have to say I have not necessarily looked at every single profession, but all the ones I'm aware of, there are competencies built in to requirements for entry to practice related to safety. So the opportunity, I think now, though, as things are shifting in terms of how curriculum is delivered and so on, is to think about how do we make sure that that continues to be baked in and that we support people in that path. So, for example, we have a ton of nursing programs across the country who are using team steps. This is a set of simulations that were originally developed in the US. We brought them up to Canada, adapted them for use here, that support effective teamwork for safer care. And how do you support people to start feeling comfortable to speak up? How do you have that experience in a simulated way of how would you address these kind of questions? How would you spot potential issues and opportunities? So, we're starting to see people, because there is less time often in clinical at the bedside or at the point of care, given the changes in how care and how curriculum is delivered. But there are different tools and ways we can use to bring some of that core competency into programs. I'm also a big fan of how do we make sure that we're embedding safety throughout the curriculum. So it shouldn't just be the lecture on a Thursday afternoon in February. We're all toast if that happens. So how can we support faculty and preceptors and students to be bringing that perspective in to each and everything that they do, rather than as a standard? Because we need it to be fully integrated when they're caring on an ongoing basis. So if we teach it separately only, it's then harder to integrate. So we need both ends.
Thank you very much for a great talk. At the risk of sort of going back on the first question about counseling patient safety in a negative way, so first, do you have a sense of, so you mentioned that statistic of, I think, 7.5% of patients have some sort of adverse incident. Do you have a sense of what a more reasonable target would be? And I know that's a very kind of crude measure, but saying kind of international comparisons, for example. And I guess sort of related to that, do you have any views on the role of technology in kind of achieving that, and in particular sort of Humber River Hospital and kind of AI, remote patient monitoring, some of those things? Thanks.
Oh, I'm not supposed to move up. I'm in trouble for that. Thank you, Maria, much appreciated. So let me take the two parts of your question separately. So first part of the question was really around the measurement. And there have been a number of countries that have done studies similar to the Baker Norton study. Unfortunately, the methodologies have been different enough that they're really hard to compare. So there's not really a great comparator on that front. There is a process underway right now in Canada to repeat, but also expand on that original study. And that may get us closer to being able to do comparisons with some of the more recent studies that have been done in that space. So I don't have a good answer to that first question, but hopefully good colleagues who are working on that in the academic world may be coming soon. The second part of the question on technology, I think, is super important. And AI, like I spent the day actually yesterday thinking about AI. AI, like any other technology, can promote safety or can get in the way. And so I think our opportunity with any new technology, including AI, is to really think about how do we push towards the benefits and mitigate the potential risks. So a couple of years ago, for instance, we hosted a policy lab around the use of AI in healthcare and opportunities for using that technology towards better, safer care. It was not at all about the technology, right? It was really around how do you structure. And some of the kinds of things that came up there were, let's not start from the premise that we're adopting AI. Let's start from the premise of the care problem or the policy and system problem that we're trying to solve. And then AI may be part of that solution, can be actually quite effective in that context in some circumstances. But usually it's not only any technology, right? Usually it's also around the combination of technology and changes in models of care and other policies and processes that make that happen. I think one of the other potential opportunities related to AI, again, if we do it well, is around reducing administrative burden and creating space for people to care. Because we know that patients can't be safe if healthcare providers aren't safe. And if healthcare providers are tired and overwhelmed, that's hard to create a safe environment. So to the extent that we can use some of these technologies to create those opportunities, we really then can look at liberating the opportunity for better, safer care as part of that process. So probably all of you have heard about the ambient scribe type, right? So this is the computer that listens to what's happening in a consultation, extracts key information. And these days usually then creates a summary that you then have to copy and paste into a record, but in a more fulsome implementation would also have a fully integrated approach into the record, would potentially flag from a decision support point of view. So, what we're seeing from the early studies of that in primary care in Canada is that when well implemented, it can seriously cut into what sometimes physicians call pajama time. So the time at the end of the day where you have to go back to your charts and document and follow up, do that kind of thing. But if it's implemented badly, it can get in the way. So let's make sure as we're implementing any of these new technologies that we get ahead of that. And so we think we pre-brief, to use that example that I was using earlier, right? We pre-brief. How do we make sure that we're ending up in a good place? So I'll just give you one example of that. So a while ago now, I saw a demo of an AI that converted a short, it was like literally less than a line, description for a patient with diabetes about their condition, into a full SOAP note that would be attached as part of a referral. And on the surface, it looked super impressive, right? Because all of a sudden these slightly anachronistic abbreviations and a bunch of, very tight jargon got converted into this fully readable, fully organized note. But there was no more information than that original one line, right? AI can't make up, or shouldn't, sometimes it does, shouldn't make up that information. So I had this vision in my mind of like that short being converted into this beautiful SOAP note. And then at the specialist end, a different AI converting the detailed, SOAP note and referral that had been sent back into a very short snippet of information, which adds value to exactly nobody. And adds potential risk in the conversion and return. So I think that is the opportunity, is to use exactly the kinds of rethinking patient safety approaches we've been talking about to look forward, so that we're looking at the potential for future safety and how do we support and reinforce that using technology and avoid some of the pitfalls that we could
Okay, so we have a few questions online. The first one is for individuals who are not directly involved in patient safety. How do they, or how would you encourage them to integrate it into their work? The example given was the health ministry.
So super important question. And I think I'll bring us back to everybody is involved in patient safety. So I think the interesting thing to start by thinking about, and one way of doing this, but not the only way, would be to start with the Rethinking Patient Safety discussion guide, is to say, how does my work influence? Where are the connection points to safety? So for instance, if I've got colleagues in Health Canada who are involved in the development of the new oral health program that's been rolled out. Depending on the choice that they make about how that gets rolled out, that has the opportunity to fundamentally improve oral health for lots of people across the country and to build and bake in higher quality and safer. Or if it was rolled out differently, it could actually present silos and barriers that would get in the way of better, safer care. So in that context at a policy level, there's the opportunity to think about safety absolutely in that safer care tomorrow way, about how can I contribute to supporting that better, safer care. Equally, many folks in ministries have the opportunity to think about the policies that we've put in place over the years. What continues to serve us? What continues to be a valid and helpful mental model that drives that policy? And where might there be opportunities to tweak that, as in the examples with paramedics in palliative care, where some changes in those policies enabled a new care model that delivered value on the ground? So no matter what our role is, I think there's an opportunity, but sometimes it does require thinking several steps in terms of what's that logic train down the path of how can the decisions that I make, the choices that I make, influence safer care for folks.
So we'll stay online, and then if there are more questions, we'll come back in a second. So the next question was, the NHS has introduced a patient care coordinator. And they're using what's called now Martha's Care, where the patient care team, so whether or not it's family, caregivers, the actual clinical team, have access 24/7 to an alternate or different voice if they have concerns about the patient themselves. Is there a program that you could see in Canada? How would we get there? What are the alternatives that we have here?
Yeah, so I think, here's a great example of collective learning from experience. And, there's been related initiatives over the years. So for instance, in Australia, they called it Between the Flags. So there were opportunities for, ensuring safety in a zone, and if it went outside the zone, there was an opportunity. There's also been initiatives in a number of countries, including many organizations in Canada, where patients and families can effectively pull the fire alarm and say, we need a rapid response care team here now, because we know something's not right. So there absolutely are examples within Canada where that kind of approach has been used. And there's good information about how to set up that kind of approach to support safer care. Now, that's in an acute care context typically that those have been used, less common in other contexts in a Canadian environment, whereas the new process in the UK is intended to be more cross-cutting across a broader range in the health sector. So I think, here's an example of a pre-brief, right? So suppose we were to do that in whatever context, maybe the person who asked the question about the ministry, the last question, or whatever context you work in. Suppose we had that kind of system. What would it look like in the context in which you work? How might that work? Where would that help to add slices of cheese to our Swiss cheese model that would potentially stop things falling? How might we design that kind of approach? It's unlikely, given the nature of constitutional responsibility for healthcare, that we would set that up federally in Canada. But what are the intervention points that might adapt to our context? And also, if this is something you're thinking about, there are plenty of people who have done it institution by institution. So, let's learn from them. Let's learn from their experiences about what's worked well, even better if, so that we can avoid the blind alleys that sometimes you have to go down in the path of innovation and double down on the paths that have been successful in taking.
So I know I mentioned more questions, but we are flat out of time. So I want to thank everybody in person here today. There is food for you as you leave, so feel free to take some. For those of you online, thank you very much for joining us and have a wonderful day. Thank you.